Thank you, Ruth. I just want to point out you made some excellent points. I continue to sponsor and push legislation that would provide some tax credits to employers who hire an individual who's graduated from a drug court or successfully completed the judicial diversion program, something of that sort. Because that's that's a key point in terms of helping someone start over in terms of their lives. This has all been very good comments. We want to hear from everyone, but I wanted to specifically turn our attention to some of our law enforcement officials. We have our county judge, Judge Burns, who I must say we were just chatting earlier a few years ago when we were each being sworn in for our new terms. Judge Burns really, for the first time, a few years ago, openly, even at that kind of joyous occasion on a New Year's Day, he talked about the heroin problem in Otsego County, and it's serious, it's widespread, and we needed to get on top of it, and I appreciate that, Judge. And also, we have our two district attorneys here as well as other law enforcement, and I wanted to hear from all of you in terms of what your thoughts were in terms of the current laws on the book. Are they helping? Are they hurting? What measures would you like to see to better assist you in doing your work, both in dealing with this from a law enforcement point of view, but also moving people toward a life of recovery?
Senator, we'd like to defer to the judge to make sure we don't have any future problems in his courtroom. So.
Okay.
Smart move.
Thank you, Joseph.
Would you get up to the mic?
All right. Very briefly, some of the numbers which I find startling. Up until about 2005, in Otsego County, we averaged about 5 felony indictments a year for those involved with opiates or heroin. By 2012, we're averaging over 50 people a year. 1 or 2, maybe 3 kids in foster care back in 2005 due to their parents' use of opiates. By 2012, 2013, we were up over 20. So the impact on the community, both financially and in terms of human costs, has been enormous, and particularly with the kids in foster care, it's generational. In the response from the courts and the district attorney's offices really started before this specific problem, but it was a recognition that much of the substance use disorder issue should be treated as a public health issue, not as a criminal law issue. And the treatment courts were started as partnerships, and it's not just in our county, in Shenango County, but in every county in the state. And the treatment courts are partnerships between the courts, legal counsel, law enforcement, treatment providers, and I absolutely include both mental health and substance use disorder treatment providers in that. Local colleges like this college, local human service agencies in our county, Catholic Charities, Opportunities for Otsego, LEAF, a real multidisciplinary, community-based approach to this problem. The laws that have been passed in response to this system, some have been enormously helpful. There's a judicial diversion law now, and through that and our prior efforts, we've diverted close to 500 people in 15 years. These are nonviolent felons, and just a quick word on that. Dr. Dostal's dealing with these folks before the onset of the full addiction. She's involved with preventive services. By the time they come to me, they are adjudicated nonviolent felons or people whose children have been removed or are about to be removed and placed into foster care because of their involvement with the criminal justice system. The increase in crime, I think, has been significant, and I say nonviolent crime, but the burglaries, the grand larcenies, the forgeries, all of those things have made a significant impact on our community. And the drug court philosophy is if we can break this cycle of addiction, we can promote public safety and help take care of our neighbors at the same time. The diversion laws, which the legislature passed, allow us to do that and address some of the other issues that were raised, such as to help eliminate the stigma of a felony conviction when trying to get a new job. As a judge, if somebody successfully completes an intensive treatment program, I can wipe out that felony conviction. I can go back in time before they even came to me and get rid of certain misdemeanor convictions as well. That helps the reentry process. one of the most important changes in the law that I believe is made in the last few years is a recognition by the legislature that this epidemic doesn't happen in a vacuum. It's not just hospitals who are providing painkillers. There is a segment of our society that manufactures and distributes massive amounts of heroin. And this poison is killing people in our community. And a few years ago, the Senate passed a major drug trafficker law which enhanced or made longer sentences for those kingpins, those manufacturing and distributing things, not the street-level dealers, many of whom are selling a bag of heroin and their pay is they get to keep a bag of heroin, but to turn law enforcement and the court's efforts towards the major traffickers. That's been a significant, I think, improvement. I'm not sure if this district attorney has a distinction of the first two major trafficker convictions in the state, but certainly among them, and that was based on investigations done by Sheriff Devlin's individuals. But these are the people who are really responsible for bringing this into our community. In terms of resources, I absolutely think additional treatment, inpatient beds, detox facilities, the ability to provide meaningful long-term treatment is essential, but it should not come at the cost of diverting resources away from law enforcement, away from the court system, and really attacking this at the supply side. I don't want to lose sight of that as well, because I think that's a significant factor in this problem, the enormous money that can be made. And again, from my perspective, these people are predators, and they're taking away people's money, their health, and their very lives. And I applaud the efforts of the legislature to really turn the focus on those individuals who are the major traffickers.
Thank you. There certainly is a big difference from someone who's addicted and someone who's profiting on the addiction of others.
Absolutely.
Any other comments from our law enforcement?
I would comment on what you just commented on, Senator. When I first took office, our major drug in Otsego County was cocaine. And cocaine dealers were generally in it to make money. And we treated them pretty much as dealers. They get caught, they were convicted, and they were sent to prison. And at some point, and I think Judge Burns helped me change my mind a little bit. I don't tend to be very warm and fuzzy, but I got to the point where I saw that a lot of what we would consider a dealer here in Otsego County with heroin was really not a dealer. It was somebody who was being taken advantage of by someone who was a dealer. They would convince them to sell for them or mule for them or carry and do their bidding for them and pay them in heroin. One of the biggest, the first kingpin, and it was the first kingpin in conviction, and I'm not sure that it's a distinction for our county certainly, but it was the first major trafficker conviction in New York State after a jury trial was in Otsego County, and the guy's name was Jose Rodriguez. And he was the first heroin dealer I'd ever encountered, and I first prosecuted him in 2005, and we sent him to prison for 2.5 years, and he got at shock, and he got out, and then he thought he would run his whole organization from New York City, and he did. If you wanted heroin in Otsego County, and he sold over 90% of all heroin in Otsego County, you called him in the Bronx, and he would say, okay, you go meet somebody at Walmart in 10 minutes, and they'll be there, and then he would send his mule with the drugs. So it was a 3 and 4 year operation between the sheriff's office, Otsego County, the Otsego County Sheriff's Office, and the Oneonta City Police, in order to catch enough of these people and roll them and turn them and get them to testify against Jose Rodriguez, who got over 40 years in state prison after trial and deserved every day of it. I complain still at times because I put people in prison, or the judge puts them in prison, but I prosecute them, and I give them 5 years, and the next day I'm walking down the street, and there they go down the street. I say, what's going on here? I mean, how do they get out in no time? I think that, and I'm not saying it's this part of the state legislature, but I think that there's been a lot of concern over years and years that district attorneys overstep their bounds, and people worried about the Rockefeller drug laws, et cetera, et cetera. And I think if you were to go back and look at how people are actually treated, that people are getting more time now than they were under the Rockefeller drug laws, because district attorneys, I believe, most of them, use their discretion, and we only put the people who really deserve to be in prison for a long time in prison for a long time. And at times now, if I have somebody that I really believe is a big dealer and I don't have a lot on them, I can't get a lot of time on them. But for the most part, with a major trafficker, we do it. And these smaller people that are dealing, I now treat differently, and now we steer much more towards treatment than we do to prison, because they aren't selling because they want to make money. They're selling because they have a drug habit, and sending them to prison doesn't do anything. It doesn't help anything. It simply prolongs them from they're just going to get out and start again. So it's a huge difference in how we treat heroin than how we used to treat, or still do treat, other drugs that aren't nearly as addictive.
Thank you, Senator. In my towns, I'm going to give you the update from Shenango County. We are a small rural town. We don't have the two colleges that you have in the beautiful Cooperstown that you have here in Otsego County. But we do have the problems of our own. I checked with our officers and our public officials before I came over here today. I checked with the Sheriff's Department, and they estimated there were approximately 10 deaths due to heroin in our county last year. I talked to our city police department, and he informed me that the good news that the heroin arrests for 2015 were actually down, and that we had done a good job at fighting the influx of heroin in our particular county. But even with the arrests and prosecutions down, 3/4 of our drug court people are in drug court because of use and abuse of heroin. So what we've done, just like John's done, we don't have the scale that they have over here, but when we see people from out of town coming into our community to sell dope, we find them, we target them, and we remove them. And the word's out that if you come to upstate New York, if you come to my county, or you come to Otsego County, and you get caught selling dope, you're going to go to prison for a long time. We've also taken a view with the people who are selling dope for their personal, addiction. They're viewed a different way. We try to get the people into drug court. We have a very conservative community. So if I tell everyone that I want to give everybody a hug to get them out of drug addiction, I'm going to be out of office very soon. But if I can say, listen, we are going to give these people the opportunity to prove themselves to everyone in our community. We're going to give them a hand, we're going to put them on the right road, and we're going to give them the opportunity to work their way back in the community. How does that help me? It keeps them out of our county jail for a year, keeps them out of state prison, and no matter when they come back from state prison, if I ship them, they're always coming back. So we're trying to give them the services that they can need to change their life up front, and that's what we've been doing not only in our county but throughout the state. That being said, there are very serious issues. I talked to public health today. They told me 3 years ago there were 2 to 5 cases of Hep C in our county. There are now 230. I don't know what the math is there, but that's a crisis. That means there's a lot more people using needles, having health issues, and from the people in that world, and I don't expect to know those numbers, that is a phenomenal cost to the community to deal with the Hep C crisis, more than incarceration, more than the lifetime cost of help. We need to focus on keeping our people safe and healthy. The next, I spoke to our drug court coordinator, who does most of the work. People here today are on our drug court team, and they do I can't make it to every meeting. I try to get staff there as much as I can. But I came down to Jim Everard, who's our director, and said, I'm going to this meeting today. What would you like me to speak about? And he said, you know what, Joe, the biggest problem we have is when our people need services, there are roadblocks to getting in. Whether there's a bed in New Horizons or not, the guy, if he's in jail, he's not eligible for services. If he's out of jail, well, he's not addicted and he's not in crisis. Well, he just got out of jail. Those people aren't getting in. And a lot of times, in my experience, and then I'll let someone else speak, is that heroin is the worst drug we've ever had. They can be in jail for 9 months. Used to be you get the cocaine people, even the crack people, if they were removed from the drug from a certain period of time, most of them, the light turned on. The light bulb was there. This is killing me. My experience with the people who are addicted to heroin is they get out no matter what the time. If you don't provide them the services they need, you don't get them a place to live away from their enemies, their frenemies, then there is absolutely no chance of success, and they're very likely to overdose and die because they go back into a world where they haven't been using narcotic drug, they ingest it in their body, and many times in our county we've had the 24-hour overdose, immediately released from jail, and boom, they've died from the overdose. That's the 30-second version of what's going on. It's not just in Shenango County or Otsego County. It's all over the state, and if everybody works together, and if we get people in. And the last thing is, we have a young man who was a heroin addict in our county who went down to Florida, and he opened his own rehab center, and we send our kids there. And that's because of money. He was a kid, he didn't have a college education, he got certified in whatever he needs in Florida, and he's able to do there because of the lack, I don't want to say lack of regulation, but we can't tie our hands here, and everybody who's trying to do something good, make it unprofitable for the hospital, can't get involved in providing this service. We need to find a way to provide that service. If they can do it in California and Malibu, they can do it here in upstate New York. Thank you. That's all I have.
Thank you, Joe. And our men in uniform here who are on the front lines every day or on the streets, I'd like to hear your perspective in terms of, you know, what laws are in books today that are working, and what, if there's anything you need from us. Anything further?
Sheriff, I'll refer to you because you're doing a lot of active cases.
Thank you, Sheriff. First of all, I'd just like to say again, thank you, Senator Seward, for hosting this and bringing us all together, because, you know, we've said all over the place we're not going to rest our way out of this situation. It's going to take a collaborative approach. And, you know, I can't agree with the panelists more that have spoken today. Judge Burns, both our DAs. I mean, you just want to say that there's no other way to say it. They're right on the money when it comes to the problems that we face. So I'm not going to get into, you know, our support of the treatment services. It's clearly there. We definitely need better treatment services, more available treatment services if we're going to make a difference. We currently look at this as two different tracks. It's been talked to today. You have your addicts and you have your businessmen. And you can't treat one like the other, either way. So your addicts, you really need to get them the services that they need to bring them back to begin being productive members of society. And the dealers, you need to hammer. No way about it. And what we're seeing a little bit is a manipulation on both sides. And I'm just going to bring up a couple of things I think that might be helpful. We have a very successful drug court in Delaware County, as we do in the counties surrounding us. It works very well. We think that we're very conservative in our approach to the people that we send to drug court. The diversion laws are great. However, you know, I think it was D.A. Mule that brought up the Rockefeller drug laws. A lot of that stuff, there was some babies that got thrown out with a bathwater on that. And we need to bring back some minimum sentences in regard to some of these businessmen drug dealers, so that the courts and the district attorneys, the prosecutors have the teeth and the tools they need to really give these people the punishment they deserve, because they do. They're ruining our communities. They're victimizing people. They really are. They're taking advantage of our weakest and most vulnerable populations within our counties, and they're literally victimizing these people. A couple weeks ago, where I arrived on a scene of a significant operation that we took down a meth house in the village of Walton, and the first thing I saw when I got out of my car was a 12-year-old boy carrying his 3-year-old sister out of the house. And it's heartbreaking. And this isn't something we're just seeing randomly. This is something we're seeing on a regular basis. The other thing that's I would feel neglectful if I didn't mention it, is the majority of these people that we're arresting, whether it be the addicts that we're arresting for the petty offenses or the dealers, the people that we're arresting, 9 out of 10 of them, if not more, are on public assistance. Okay? And I believe there's some welfare reform that needs to happen within New York State, and that could be beneficial in helping us address these problems. First of all, let's talk about the first track, the treatment. If we brought back urine screening, or if we shouldn't say we brought back, if we implemented urine screening within our public assistance population, again, our poor, impoverished citizens who are being victimized by these dealers, we may be able to catch some of these families. We may be able to catch some of these individuals before it's too late. We may be able to get them in the beginning stages of their addictions before they become full-out drug addicts and start committing offenses and crimes to support their habits. This may be helpful. It may be something we can do to address these things in the early stages, a more preventative piece. The second thing, as far as the businessmen, because let me back up, because these victims are losing everything. They're losing their families. We heard about the increased foster care. We have significant increased foster care. It's devastating their lives. And it's generational, as the DA said. The businessmen, why do we have repeat drug offenders on public, or repeat businessmen, felons, who have been received prison sentences on multiple occasions, coming out and getting public assistance benefits? Especially the repeat felons. Why are the taxpayers in any way supplementing the lifestyle of repeated felons who are destroying our communities and of the hardworking taxpayers who are struggling to maintain these communities? Maybe we should bring back fingerprint screening. This is something we took away not too long ago. And deny public assistance to those felon businessmen. The cost savings realized could be applied to treatment services we so desperately need, and enhance the enforcement efforts on the law enforcement side. So, I mean, I think this is just a piece that needs to be looked at. It's been mentioned a bunch of times here today. We need to look at all facets. We can't focus just on one. We need to look at everything. And I truly believe that welfare reform needs to be looked at as well as part of addressing this problem.
Thank you, Greg. Any other comments from law enforcement?
I just, in my capacity here, I try to look at the overall health and safety of the community. And with that, I've noticed trends and problems before. And one of it, of course, is why we're here today talking about it. And I could reiterate what everyone else has already said. That was some of the points I mark here. I'm checking off as other people say it. There's one thing that was mentioned once, and I think that maybe it should be brought about again. There was, of course, passed as the I-STOP regulation. That was to try and stop the multiple issuance of opiate prescriptions. Sometimes I think that maybe there ought to be an I don't start, because it seems as though these prescriptions come out a little too quick, a little too fast, and a little too young. Chief Cover mentioned 41 out of 43 of his people went in, all started with prescription medications. I've had incidents to see where children as young as 8 years old are getting prescription hydrocodone. And there has been stats that have come up and said that if they start a prescription opiate before the age of 15, they're 70% more likely to become addicts. I'm not sure if that's something legislation could talk about, could look into, could regulate, but I think it's a discussion that needs to be had. The only other thing I can really throw out there, and it's been brought up once or twice again, is post-treatment housing and employment. Because in the end, I think you really have to provide hope. That's all I have.
Yes.
Chief, is it?
No, Lieutenant.
Lieutenant,
Yep.
Are you finding more of, when you go into an area, more of a prescription Oxycontin, oxycodone, or are you finding the bags of heroin? Because we have found out that, a lot of the bags are being cut with the fentanyl, and that's, used in anesthesia. But are you finding more pill form or more actual heroin bags?
Before I-STOP legislation, we found pills. Since I-STOP legislation, now we find bags.
Gotcha.
If you speak to, I interviewed dozens of low-level street dealers, which we would call a lower-level street dealer, and you ask them how they got addicted to opioids, and they all will say prescription pain pills.
John, 1,000%. The forum that I went down to in New Orleans, number one reason was the overprescription of Oxycontin, oxycodone. You have good kids that are going in for a simple shoulder surgery or going for a tooth extraction. They go in and get a 60 count of Oxycontin, use 2 of them. The parents don't even know what to do. The other kids come in, their friends come in, and they actually steal it out of the medicine cabinet. They're stealing it from our veterans. They're stealing it from our seniors. They're going in and they're randomly looking through all the medicine cabinets and getting these medications.
The success of the one-stop program has created a major heroin problem. I mean, I don't see the volume of pills, and correct me if I'm wrong, if anyone does anymore, that we did 4 years ago. So we solved one problem, we got another one to deal with.
if you look at the numbers, it appears that there's been success with it. But I will tell you, practicing, I feel very much that it is something that we're not seeing, the drug-seeking behaviors. And interestingly, patients now are aware of it and actually will understand it. So if you get into this conversation with them and you bring it up, they'll back off immediately and say, "Hey, no problem. I don't want to create any issues." I think I really just want to. I agree very much with everybody who's discussed creating local treatment programs that are real time, meaning that when I have a patient in the emergency department, I think Chief Colvert hit the nail on the head when he said, you've got a moment that you can make a difference. And to be able to pick up the phone and start that treatment process for a patient would be hugely helpful to us. We get different kinds of patients in the emergency department. Some come in, you have a conversation with them. Maybe they're there for a sore throat, you have a conversation with them, and they're very open to getting treatment, and this is, a patient that needs, specific resources that I can try to go to our social worker, but they're overworked, they're dealing with the mental health side of it and trying to find them the kind of help that they need. Probably the most troubling and the most difficult patients to take care of with are those that come in more under the auspice of an intervention. They're there with family members. There's a lot of anxiety. There's a lot of stress both on the patient side, the family side. There's very much back to the sense of, this is something that if you don't strike now, you're going to miss an opportunity to make a huge difference in somebody's life. And again, we don't have a mechanism to get those patients the help that they need immediately. So if I could advocate for one thing or one gap in care that we provide right now is really having programs, and I would defer to the experts as to what those programs look like, but they need to be local, they need to be real time, meaning I can pick up the phone and say it's a done deal. It needs to be a pull system. I refer to that as the number of hoops that you have to jump through to get one of these 6 beds that almost always are taken. And I don't mean to say that there's just 6 beds, but they're an hour away, and we'll talk to you tomorrow and send us this, and they have to be that, and you have to do this test. So, somebody brought up earlier the notion of having a navigator that navigates or is an advocate for these patients. I was going to call it a coordinator, but if there was somebody locally or at the hospital level, that we could pass off patient information and they had the ability to get these patients I could hand off and I knew this patient was going to get where they need to be. And then we could establish those programs to get them there. I think that would be hugely helpful. I got off track a bit. The other thing that I just wanted to mention, what we started doing, I'm going to guess about a year and a half ago, back, the iStop, I think has been very helpful. The emergency physicians with the primary care physicians who actually see, this is probably a multi-times daily issue for them, whereas in the emergency department, to some degree, I'm going to guess 4 or 5 times a week we're seeing these patients. But having a conversation about coordinating the medications that we're writing out of the emergency department. I would have to imagine the primary care physicians find it, somewhat disrespectful in that they establish these programs. They work very hard with their patients. And when I say programs, a program with that specific patient that they're going to get the medications that they've discussed. And then they come to the emergency department and, they get, 60 hydrocodone or whatever it may be, which is totally against what a doctor has worked very hard with their patient. So we want to coordinate, what we're prescribing not to infringe on that relationship or that agreement or the well-being of the patient. And it was great in that we came up with some prescribing guidelines. And again, you can never go to any one clinician and say you can't do this because circumstances always vary. But the guidelines really focused on substitutes for opiates, looking at the non-steroidal anti-inflammatories, which are wonderful medications when they're used properly. And the other thing we really looked at is curtailing the length of the prescriptions that we're writing, which iStop does wonderfully. You know, it gives you that, you know, less than 5-day out, which I think is there's no reason why somebody brought up an example. An ED physician should be writing somebody for 60 pain pills. I mean, it just, you know, we're acute care. Our job is to acutely take care of the pain issue and get them to a specialist. So we came up with these guidelines, which, you know, along with the iStop, have been hugely helpful in that it, you know, I think it empowered, or our ED physicians felt empowered now that they had something from an institutional level that we could, or they individually could refer back to and say, look, this is what we do. It's not what I'm doing. I'm not the bad guy. And it is, you know, we started this project. We looked at these patients coming through. The goal is to go back and look at, you know, how has this been successful? Are we getting the patients back to where they need? And are the prescriptions coming from the folks that originally wrote it? Do they have one provider essentially that are prescribing the medication?